Can we have the slide? So, first of all, I would like to tell Goutom is a very good friend of mine. So, and we are not competitor to each other. This is the first message, particularly from the audience sake, and that to have a take-home message. For the debate sake, definitely I will stand our point, and I will show in the following slides just few research evidences, not just on my talk. It is the research evidences and what is our practical experience, why soft tissue is the first to be tackled rather than jumping upon the skeletal tissue. We all know in 1981 CPAP was considered as the gold standard and treatment of moderate to severe OSA, but in spite of the best possible efforts on the part of the both treatment providers, that is doctors and technologists, and beneficiaries, that is our patients, the long-term compliance of CPAP has reached a plateau, and it is very unrealistic to actually attain further higher compliance rate anymore. And there is a vast body of literature exists on long-term compliance of CPAP is as low as even 29% in some cases. So we ENT people are in a unique position to offer a variety of surgical interventions to alleviate upper airway obstructions. And this picture actually tells us why soft tissue has to be addressed with a bit age-on more importance in comparison to the skeletal, because multiple level of airway obstruction. Patient snores. In sleep apnea, obstructive sleep apnea, patient come down to our chamber with a complaint of snoring, and it is actually patient doesn't know anything about obstructive sleep apnea. Presenting symptom in 99.99% cases is snoring only, particularly in adult patients. So where does the snoring originate from? It is nothing but palate. The palatal vibration is exactly where the snoring sound originates from, number one. Number two is the nose. And nose in comparison to the DNS, that is the septal deviation. If we consider that as a structural fixed deformity, maybe my beloved friend, my learned friend Dr. Goutom will argue that septum is also a skeletal structure. My point is the turbinates. My point is the turbinate, the soft tissue turbinate, the turbinate hypertrophy is actually, the evidence says, plays more in obstructive sleep apnea rather than the fixed structural defect like septal deviation. And next, the tongue base. So particularly in CPAP non-compliant patients, when the patients are being referred from our physician colleagues, they put the patients under CPAP first, always, and many times without even having any ENT evaluation. Unfortunate. Nowadays their approach gradually has improved and changed a lot. But in most of the cases, after doing the PhD, they just offer CPAP. And when CPAP fails, when the patient is non-compliant, then they send those patients to us, and by just doing a drug-induced sleep endoscopy, or maybe a CNMRI, that is a separate debate. But suppose our DICE, the gold standard drug-induced sleep endoscopy, in most of the cases, the failure of CPAP happens where? It is actually the larynx and the tongue base, that is the hypopharynx. So the tongue base, again a soft tissue structure. This tongue base and the epiglottis, this collapse is the most common finding in CPAP non-compliant patients. So our approach has been changed. Reconstructive surgery rather than the destructive surgery is the current concept, and I defend my case as skeletal surgery in sleep apnea is actually not an orthognathic surgery. The point has to be taken very carefully. The skeletal sleep surgery, whatever be the maxillomandibular advancement, be it advancement genioplasty, this surgically assisted rapid palatal expansion, all these surgeries, dome, distraction, osteogenesis, these are not orthognathic surgery. The primary intention is whether the patient was actually presenting with a complaint of snoring and sleep apnea, and whether the polysomnographic documentation has been done or not. So reconstructive surgery is the key nowadays, rather than destructive. We don't do any kind of destructive surgery anymore. So why don't we approach the soft tissue first? So the unanswered questions is, which structures appear obstructive or collapsible, and which truly need treatment to improve the patient status with least morbidity? In the International Journal for Pastors, I like this slide. What matters more, container or content? The soft tissue, we ENT surgeons dealing with the content, and our maxillofacial friends dealing with the container. So what matters more? With advanced palatoplasty, with different kind of advanced palatopharyngoplasty techniques, a need of multiple structural surgery is actually reduced. We're actually advancing not just uvulopalatopharyngoplasty and addressing the retropalatal collapse. We are giving much more attention to the lateral collapse, and with combination of different kind of palatopharyngoplasty procedures, we are achieving a much greater result than actually anticipated or assumed by our maxillofacial surgery friends. And the AHI floor for most upper airway surgical publication is in the teens. That means after the surgery, we can achieve postoperative AHI in the range of 13 to 19, that is in the teens. So patients seek improvement in quality of life with less medical risk. It is their demand. How many of our patients, when they present to us, just even if we give the option, yes, you have some skeletal compromised, then they jolly well sign. So my argument on favor of this soft tissue surgery is, patient want less risk, patient wants less destructive surgery. Minimally invasive is the current concept. That is why the BART pharyngoplasty came into vogue. And now some research evidence. In the Journal of Clinical Sleep Medicine by our dear friend Dr. Ofer Jagovic, the AHI outcome in this particular graph, it is very clear. The AHI outcome after palatopharyngoplasty has been drastically improved in different combination of palatopharyngoplasty. Even it is compared when there is existing tongue-based collapse or not. And it is clearly stated that in this research evidence, sleep endoscopy shows, in the postoperative sleep endoscopy shows, we could achieve much more better AHI in comparison to the previous classical UTPP. So our maxillofacial friends argument that we can achieve better result with MMA in comparison to UPP, it is no more in practice, because there are 6-7 generations of lateral pharyngoplasty proposed by our dear friend Professor Michel Kahali from Brazil. They actually suggested that we can achieve a very good result with different kinds of permutation, combination, pharyngoplasty, relocation, BART, and different generations. Our dear friend Dr. Kenny Pang and Brian Rottenberg, their expansion sphincter pharyngoplasty, wonderfully demonstrated by Dr. Vijay Krishnan yesterday in the live surgical workshop. There are some, again, modifications of the expansion sphincter pharyngoplasty, the classical, the modified. So it also can achieve a very good result, and everyone is proposing we should propose the soft tissue surgery first. Professor Claudio Vigili, another giant father figure in our obstructive sleep apnea surgical practice across the globe, barbed reposition pharyngoplasty for OSA, a feasibility, safety, efficacy, and teachability, his benchmark pilot study. We are on the giant's shoulders. His study based upon the comparison to classical UPPP, and this barbed reposition pharyngoplasty, the kind what basically Dr. Vijay and Dr. Vikas Agarwal did yesterday. We're using this. We are exploiting the property of the barb in our obstructive sleep apnea surgery to reduce the vibration and the collapsibility at the level of the palate, because that is our patient symptom. Patient will bother about reduction of the snoring only. Actually, these patients are not caring about the cosmetic. So that is my argument. Next, zeta palatopharyngoplasty, another technique proposed by our another father figure, Professor Michael Friedman. The zeta palatopharyngoplasty is a very good technique, but just by doing that technique, we can achieve lateral and depth simultaneously both. Because the argument on behalf of our maxillofacial colleagues is not only just forward protrusion, it is much more important by doing MMA actually to tighten the lateral wall. We shouldn't forget, the philosophy of maxillomandibular advancement is more of actually tightening of the lateral wall rather than just by anterior protrusion, because in complete concentric collapse, CCC, which is actually an absolute contraindication for hypoglossal nerve pacemaker, MMA is being proposed as per Stanford protocol and the recent guideline. You do MMA first, just to tighten the lateral wall, so that we can convert this complete concentric collapse into an AP collapse, and now just do hypoglossal nerve pacemaker. That means to address the lateral collapse. Now, in zeta palliroplasty, by this Z, we can achieve the lateral. We can achieve the lateral dimension. I have shown yesterday also in my surgical video demonstration. We can achieve the tightening of the lateral wall as well as the width of the oropharynx and the velopharynx. Now, transnasal robotic surgery, tongue-based reduction, and supraglotoplasty for obstructive sleep apnea, there are plenty of publications. And upper airway stimulation, that is also another soft tissue surgery. So, dynamic achievement. The whole world is actually in select group of patients, less than 32 BMI, limited AHI, and in absence of complete concentric collapse, the dynamic achievement of the upper airway, we can achieve by upper airway stimulation device, that is hypoglossal nerve pacemaker. Then why to proceed for this prolonged, morbid maxillofacial surgeries? So pacemaker is also a soft tissue surgery, and moreover dynamic, not only static soft tissue. And I will rest my case with the updated Stanford sleep surgery protocol. Previously, it was the old Stanford protocol where Powell-Lilly classical protocol was the phase 1 and phase 2. I am not arguing my debate. We based upon the old protocol, the phase 1 soft tissue first, followed by phase 2, that is skeletal. So no, even in the recent and updated sleep surgery, Stanford sleep surgery protocol, the message is treat simultaneously. The topic of our debate was only skeletal, only soft tissue versus only skeletal. So I oppose, I defend my case, I object. There is nothing called only skeletal. So it should be simultaneous, and in this updated protocol also, simply we have to address the soft tissue first. And in select patients, when there is really compromised surgical anatomy, we can take help of our maxillofacial colleagues. So dear friends, I rest my case. Chairman. Thank you.
Okay, for the audience, my turn now. Small disclaimer before I start. ENT surgeons will always be my friends, despite what I say. So, Dipankar was telling me, or telling us, that he was talking about tongue base, he was talking about soft palate, he was talking about a lot of soft tissue around the airway. I just say, give me that one surgery that does it all. And if there's one surgery that does it all, then it's MMA. Because I don't have to go around doing a uvulopalatoplasty or a tongue-based reduction or a xenopharyngoplasty and different kind of surgeries to address one problem. I mean, what would you do if you were given a one-stop solution to your problem? You would just go for that. So that's for starters. Then Dr. Dipankar was telling us that we'll do soft tissue surgery first and then skeletal surgery. So we are saying, look, I'll try, we'll see, if it works, it's okay. Otherwise, you can always go for the MMA. No, if MMA is the way forward based on our assessment of the patient, then that's the surgery that we have to do. It's not about the first or later. So, why skeletal surgery? Now, for a moment, forget about skeletal surgery or MMA or DOE. Any surgery for that matter, if we were going to assess how successful a surgery is or whether you should be doing that surgery or not, I think these would be the parameters that you would be looking at. Is there any indication to do this surgery? What kind of morbidity are we talking about? What's the long-term stability and patient satisfaction with this surgery? And how is this comparable to other techniques? Is it superior or inferior? And what's the evidence behind this? Okay, so let me just take each of these issues and go and ahead with the review of the literature that we have with us. Okay, so this was a review done on various modalities of surgical therapy for obstructive sleep apnea. Where if you look at the last thing, I don't know how clear that is, but it says typically MMA is reserved as a last but can also be indicated as initial surgical therapy in selected cases. Well, I will go ahead into my discussion and then we will realize that we are soon getting into a situation where probably it should always be given as the first option for any patient. And then look at the data that we have about the surgically assisted palatal expansion. And this is not from some MaxFax journal. This is from your own journal, which says that there is a 90% success rate and a 70% cure rate in people who are selected carefully though with having surgically assisted palatal expansion. 90% success rate and a cure rate of 70%. And would I settle for anything less? No. Okay, the next thing I talked about was morbidity. Now, morbidity in this was in the Journal of Oral and Maxillofacial Surgery, and one of the authors is no less than Professor Caban, who is at the Massachusetts General, and in a very reputed name in the world of MaxFax. And he says that this was a comparative study between a group of patients who had OSA and otherwise who underwent MMA, and then they came to the conclusion that although the OSA group were patients who had more comorbidities, obviously given the nature of the disease and the age, there was a relative risk of complication OSA patients as compared to other facial deformity corrections was 3, and no difference in mortality was noted. I mean, in the literature there is not even any report of mortality from maxillomandibular advancement. So which means again that the overall morbidity from a surgery, however much complex it might be, is not so much. And as I said, here is a surgery that's offering you everything in one step. So why not? Then I talked about the long-term stability and patient satisfaction. Again, this was a study which was 13 years down the line, okay? 13 years review of patients who had this procedure, and no statistically significant difference between SNA and SNB and all these angles that we find on cephalogram, which means that even over a period of 13 years, the surgery was still stable. The bony landmarks were found to be almost in the same position as they were at the time of the surgery. This will probably hurt the ENT surgeons a little bit because this is a path-breaking publication which says that they did a study on 3 groups of patients who had MMA only, who had rivulopalatinoplasty only, and a 3rd group which had both. And there they realized that significant lowering of the AHI was found only in patients who had MMA, not even the patients who had the MMA and the UBPP put together, which means that this is a far superior technique than any of the others. And last but not the least, the International Journal of Oral and Maxillofacial Surgery says that the surgical success of MMA in patients with OSA was found to be close to 100%. And okay, I will not take that maybe, but at the same time, this significantly, completely removes the necessity to do any soft tissue surgery otherwise, if this kind of result can be achieved with just MMA. So, in other words, skeletal surgery in OSA is predictable, it's stable, and I'm not saying this, this is the data that's telling us this, and it's predictable, stable, effective, and better than other surgeries in outcomes, and hence should be the gold standard in the management of OSA. And this is not an experience, in our own experience, with, in the cases that we have done, probably which is the largest in the country, in the series of cases we have done with Dr. Srinivas, I would say that our results are pretty much in line with the data that I have presented. So why not OSA and why something else? That would be my case. Thank you very much.
Thank you, Goutom, for your. Can you hear me? Yeah. Thank you very much for your side of the debate. I would like to request now Dr. Dipankar for his rebuttal. You're going to get 1 minute for the rebuttal, and then Dr. Goutom will be given 1 minute for the rebuttal.
I must say you have already lost. because in your statement you have told carefully. That means you have already told in your presentation MMA for selection carefully, quote unquote carefully, and again you are telling why not MMA for all. So I think you are actually negating your own statement. So I think there is no argument at all. So this is number one, and number two is your all the statistics, publications, and the evidence are actually for the UPPP. And already in my presentation I have shown that we have gone far away. We have gone far ahead from UPPP, reconstruct surgery, different kinds of permutation, combination, and target oriented, because these publications are kind of pre-DICE era. So after DICE, our surgery is much target oriented, tailor made. So our success is much more way. Number three, you are comparison with only AHI. Why about the quality of life? We have already reached a consensus. The surgical success should be based upon the quality of life, not the AHI number anymore. So I rest my case.
Thank you for your rebuttal. You get 1 minute.
Victory or loss is a state of mind. So what I say is that from a perspective of maxillofacial surgery and for the kind of cases, I speak, as I said, not only in the experience of our own, but also of the data. So on that context, I would say that there would be no hesitation at all from our part or my part to offer this surgery as the first call. That's what I'm going to say. So we should not get into a situation where patient has had multiple soft tissue surgeries and then doesn't improve and then get into this MMA, which by then starts becoming a more morbid and a complicated surgery for these patients.
Is that right?
Yeah.
All right. So my job is, I think, quite easy, because I think you've done your parts very beautifully. So I think, as always, when we have these debates, there is never a completely correct answer or a completely wrong answer, and that is why we have algorithms and protocols in place. You can't hit every patient with an MMA, or you have a patient with, let's say, a frequent tongue position 1 with grade 4 tonsils. You don't want to do an MMA for that guy just because his AHI is about 70, right? But having said that, like I showed yesterday, you have a patient with severe retrognathia, you have skeletal deficiencies. You don't want to be a T1 tonsil. You don't want to be doing all the surgeries that Dr. Dipankar has described. So I think there has to be an understanding and customization of treatment for our patients with the outcome in our mind, that what is it that I want to give to my patient at the end of the day. Okay, this patient comes to me with these challenges. What is the best thing that I can do for this particular patient? If it involves involving a maxillofacial surgeon, when you are doing many cases actually we do soft tissue surgery and do an advancement genioplasty. It's a mix and match. Sometimes we do domes, that is distraction osteogenesis maxillary expansion with palatal procedures. So it is always the patient that is pivotal and primary. The outcome has to be about customization and improved outcomes. Thank you, both of you.
I request Dr. Devendra Rai to hand over a memento to our